Good morning, everybody. Want to thank everybody for coming out this morning, braving the traffic, braving the construction. Every day there's new obstacles to get to campus, it seems like. They tell us at some point the project will be done. I think hopefully at some point in 2026-ish. My name is David Demore. I'm the Executive Director of the Lincy Institute in Brookings Mountain West. If you're unfamiliar with what we do, this is a little background about the Lincy Institute. We're essentially a public policy center on campus. We focus on, of course, economic development, education, governance, health, nonprofits, and social services. Our goal is to provide research to inform policy interventions to address Nevada's most pressing issues and problems. Here's some example of our recent work. One of those is a piece we did with the consulting firm Tripp Umbach last November on the care workforce and the needs in Nevada, particularly in terms of child care and elder care. And then a piece we put out earlier, I guess last week, on background on film tax credits. So if you're interested in that and what it means for Nevada, that's a good primer on the topic there. I also want to mention one resource that we do have. It's called the Data Hub. And this has largely been driven by our wonderful student research team under the guidance of Caitlin Saladino and Bill Brown. And these are essentially fact sheets, data visualizations, 1 or 2 pages that are just to provide background information about a myriad of topics. I think there's over 300 in there now across. Those are the major collections. And then you can see what we put out recently. We've also done quite a bit of work in the mental health space, particularly coming out of COVID. I like to say that was the one silver lining of COVID, was recognition of mental health challenges, particularly in Nevada. These have been long-standing, but now you finally have some momentum in this front. So these are some of the fact sheets we've done. A couple on the right are the more recent ones as well. So if you're interested in just background information on pretty much any topic related to public policy in Las Vegas, Nevada, and the Mountain West, check out the Data Hub. Some of you were probably here last April, a year ago, April. We did an event coming out of COVID, focusing on what UNLV faculty were doing to address the mental health challenges in Southern Nevada. So we had a presentation on the UNLV practice strategic plan. We had Sarah Hunt here talk about what's going on in Be Here, Nevada. At that point, you were just standing it up. Now you're year 3, I guess, at this point. Yeah, so very, very exciting there. And then we had a presentation, was the sort of introduction to multi-tiered systems for support, which you're going to learn a whole lot more about today. This was this project, and of course this event and the research has been funded by a grant through Cooperative Extension, so we're appreciative of that as well. On this one, I do want to say a couple quick thank yous and some acknowledgments. I want to thank, of course, Ashley Leclerc on our team for doing all the work to get this event together. I want to thank our friends at UNLV TV who are taping this. This will be available probably in a couple days. We'll send out a post-event email with the link to this as well, and it will live on forever on YouTube as well. And of course, I want to thank our organizers, Dr. Chris Carney, Distinguished Professor and Chair of Department of Psychology, and Dr. Kellyanne Beavers, the Coordinator for Community Outreach for the Lincy Institute, who will be, Dr. Carney will be presenting, and then Kellyanne will be leading the panel discussion afterwards. So without further ado, I'm going to turn it over to Dr. Carney.
All right. Well, good morning, everybody. Happy Election Day. My name is Christopher Carney. I'm a professor in the psychology department here at UNLV, and my associate, as Dave mentioned, is Kellyanne Beaver. She's a research associate at the Lincy Institute. We're very grateful for today's event and for everyone's attendance here. Thank you so much. What we wanted to do today was just kind of share some outcomes of funded work over the past 18 months that have been designed specifically to advance the state of children's mental health in Nevada. And although Kellyanne and I are part of the hurricane in much of this, it's important to point out that this is a strategy that involves multiple people at multiple ecological levels. It's a collective kind of process. But what I want to do today is just sort of, in my brief time, is just sort of start with some of the basics that I think a lot of us are already probably familiar with, and then sort of get into some of the snapshots of some of the findings regarding our funding over the last year and a half or so. So this is a slide that I actually showed at last year's forum. And it illustrates the rise in the percentage of mental health conditions in children and adolescents since 2012. This is parsed out by race and ethnicity according to electronic health records for 7 million children. A lot of the increase in mental health challenges over the years has been driven by increases in emotional disorders, especially anxiety, depression, suicidality. These changes may reflect more social isolation, more social media use. It's not completely clear, but certainly there's also been a concurrent rise in the number of adverse child experiences and traumatic events that children and adolescents have faced over the last 10 to 15 years or so. The good news in this graph, and this has actually been confirmed in some recent studies as well, is that there has been a recent drop in the prevalence of mental health conditions over the past 12 to 18 months or so. One possible explanation for this might be school attendance, which has also improved a bit over the last 12 to 18 months. And of course, we know that school attendance serves not just as a measure of academic support, but also a lot of non-academic support, whether it's food or mentoring or counseling, socialization, and so forth. And we know that mental health and school attendance are very much entwined. In fact, we use in our work school attendance and school attendance problems as kind of a early warning system, as a marker for mental health kind of conditions. A lot of times when kids start missing school, it's because of a mental health condition. That's one of the major drivers of school attendance problems. And if you look at chronic absenteeism rates in Nevada public schools, you see that it kind of mirrors the trends in prevalence rates for mental health conditions. So you can see that there was quite a substantial increase, especially through the pandemic years. It has improved a bit over the last couple of years, but still the chronic absenteeism rate, which is defined as missing at least 10% of school days, is still 30% in Nevada. The national rate is around 25 to 28%. So even though it has improved, it's still much higher than pre-pandemic levels. Now, the other thing to point out about this is that public school enrollment has declined quite a bit nationally and in Nevada. So nationally, it's going down about 8%. In Nevada, in Clark County in particular, it's gone down about 7.5% since 2018. A lot of families are shifting from public school to private schools, charter schools, and homeschooling, which means that a lot of kids who may have a mental health condition may not actually be counted. And so that's sort of important to sort of point out. So I'm going to talk about some things that I know that many of the people in the audience already know, but it's kind of bears repeating. The combined treatment rate for any child or adolescent mental disorder is only about 38%. So only about a third of youth who have a mental health condition actually see somebody in the community to receive community-based care for their mental health condition. And that's particularly worse for certain groups. So certainly underserved groups, so racial and sexual minorities, rural students, low-income students. It's also particularly problematic in areas where you have a lot of fragmentation of services. And so you may have areas, and certainly Clark County is one of those, where you don't have a lot of communication or collaboration between mental health, medical, residential, legal, developmental kinds of agencies. And so families a lot of times are having to navigate this sort of patchwork of systems of support to try to figure out where they should go for a particular mental health or behavioral challenge. It's also particularly worse, of course, in Nevada. We rank last. There's a recent report that confirmed that in terms of overall youth mental health rankings. I mentioned this in 2024 when I lived in Mississippi for a year, and the healthcare system there is terrible. And so the fact that we're below Mississippi is not very good. Now, there are a lot of barriers to community-based care. This is another slide that I showed last year. I know this is kind of a lot of different reasons, but they basically fall into three main categories. So one is system-level factors, and this is things like financial cost, availability of providers, and access or lack of access to affordable services. Practice-level factors as well. So if therapists have cultural and language differences from families, a lot of times there's long waiting lists or just very limited specialized care options. My adult daughter lives in California, and she told me recently she was looking for a therapist. all she could find were people that charged $400 a session, didn't take insurance, and had a 5-month minimum waiting list. I mean, so who can access that? Who can afford that? It's a little bit better in Nevada. I'll give you some characteristics later on, but not much better. And then, of course, there's a lot of personal factors as well. A lot of families find community-based care to be stigmatizing. There's transportation issues. And a lot of families struggle with mental health literacy, which is knowing when you should actually see a therapist. At what point should I bring my child to a therapist? And if so, who do I go to and where do I go to? It's very confusing to kind of navigate that landscape. So when we talk about pathways to advance children's mental health, not just in Nevada, but really nationally, there's two main sort of thrusts that clinical child psychologists sort of think about in this regard. So one is pursuing a where they are approach. And this means not necessarily waiting for families to come to community-based therapists, but actually going to settings that families typically gravitate to. And so that could be primary care settings when they visit their pediatrician. It could be faith-based settings when they visit a clergy person or go to a teen group. It could be a recreational center if they're seeing a coach or a mentor or a support group there. In the United States, the de facto mental health system for children and adolescents is the school system. So about 2/3 of all kids in this country, if they have a mental health or a behavioral challenge, the only person they're ever going to see for that is somebody at school. It's going to be a nurse or a teacher or a school-based psychologist, social worker, or counselor. That's it. And a lot of times it's just going to be one or two kinds of quick interactions. Now, a key advantage of these kind of settings, though, when you talk about these more soft entry points, is that a lot of times they're linked to other kinds of services. So schools, for example, also serve as repositories for other kinds of resources like food or sometimes even housing, employment, and other kinds of things. The other thing is that when we utilize these kind of settings, they're less stigmatizing to families. Usually they're more centrally located, so there's less transportation problems, less financial challenges. So families are a little bit more willing to sort of pursue these options. Now, the other thrust is to augment the mental health workforce, and this means increasing the number of mental health providers at different levels and in various settings. And so that could be increasing the number of licensed professionals, psychologists, for example, at the PhD or PsyD level, as well as the bachelor's level. So that's sort of another new thrust in terms of advancing mental health is how can we get people that are licensed at the bachelor's level to go out and at least do more fundamental kinds of outreach to children and adolescents who need it. And I'll talk a little bit more about that as we go along. Now, the other way to sort of think about these two pathways is to consider a model that's common to school-based service delivery, and that's a multi-tiered system of support model. And this is a framework that sort of arranges intervention or treatment or support services according to the level of student need. So tier 1 services are those that are more preventative in nature or are geared to catch problems just as they're starting to emerge. Tier 2 practices are usually those designed for more acute or emerging diagnostic kinds of problems, and then Tier 3 services are usually geared toward those problems that are more chronic and severe. And so MTSS approaches have been designed for a variety of challenges: academic, social, mental health, behavioral. We've designed a whole system just for school attendance problems. And you might sort of line these up with the two main pathways that I just talked about. So at a Tier 1 level, we're talking about really trying to emphasize a where they are approach, right? Trying to get people out into these kind of less formal settings so that we can do a lot of preventative work and sort of catch problems and nip them in the bud. When we're talking about augmenting the mental health workforce, we're talking about trying to align with Tier 2 and Tier 3. How do we get more providers out there so that we can address more diagnosable or more formal kinds of already existing problems? So these are some of the funding sources and projects that I'm going to be talking about that Kellyanne and I have been involved in over the last year and a half or so. The UNLV, UNR Cooperative Extension Grant that Dave talked about gave us a mandate to develop a community asset map of mental health providers and to do a pilot project of MTSS procedures in a kindergarten and first grade setting. Part of the mandate of that grant was to partner with folks in Reno at UNR. And so we did that. There's a group up there in the Department of Education that run MTSS programs statewide, but they've collected a lot of data, but they haven't done a lot of program evaluation. So we partnered with them to initiate that process. And I'm going to talk a little bit about our findings with respect to rural schools and special education rates in Nevada. Last year, I was able to get funding from the Fund for a Resilient Nevada, from the opioid settlement funds to develop a bachelor's degree program in children's behavioral health psychology, as well as a PsyD in clinical psychology with a pediatric and addictions emphasis. So I'll talk about that a little bit later. SB 165, sponsored by Senator Wynn, was passed this year in the Nevada legislature. It designated a new license category, which is unique to the country. It's very exciting. It's a behavioral health and wellness practitioner. And this allows funds to implement a degree program for bachelor's level students that can engage in screening, prevention, and early intervention. That's sort of where they are approach under supervision. And then SB 353, increased state support for cost-based reimbursement for university-based clinics. That's going to allow greater access to low-cost mental health services for many families in Nevada. So I just want to sort of mention some of the close collaborators in all of these projects. Obviously, as I mentioned, it's a wide ecological system. The administrative structure at UNLV has been very supportive of all these projects. Special shout out to Dean Jennifer Keene and her group that she's assembled in the College of Liberal Arts. All the people that you see at the very top of the list, her team, they best lower my blood pressure. So they're very good at what they do. The folks at UNR are those that we've worked with that run the MTSS procedures statewide in a lot of the rural and urban schools in Nevada. The folks at the Balmer Institute have been great partners in helping us design the curriculum that I'm going to talk about later for our children's behavioral health psychology program. We've worked closely with the folks at Battleborn Academy and the Hills Preschool for our K-1 project. My graduate students, as we know, graduate students do a lot of the footwork, the on-the-ground data collection kind of stuff. And my program coordinator is Mallory Constantine, who's a former Lincy fellow. She's actually helping me collect and sort of organize the practicum sites that are going to be related to the children's behavioral health psychology program. So she's grant funded on that currently. So let me start by talking a little bit about the community asset map that we developed. The first aim of the collaborative grant, the cooperative extension grant, was to develop a community asset map of mental health providers in Clark County. This eventually expanded to Nevada overall. We also expanded it to include other resources that are also listed on the site, but the primary goal is to focus on more mental health providers. So community asset mapping is done to organize available resources into some centralized mechanism like a website or a listing. And that's done in order to sort of enhance the ease of identification and connection to those resources. So the specific aim of this community asset map was for school counselors in Las Vegas who could more quickly link families to Tier 2 and Tier 3 services. So the traditional model is that you have a school counselor who, by the way, is already burdened by a lot of other tasks and roles, who encounters a student who has a mental health or behavioral challenge, and then there's this huge hunt and peck kind of method to try to find a therapist that might be available and might be able to fit a family's needs. So the goal of this website is to minimize that gap, right? So what we did was we collected a lot of information about mental health providers, and there's a variety of filters. This is the homepage, and then these are the areas of specialization that have to deal with children and adolescents. But basically, anybody can go in there. It's not just for school counselors. Anybody, of course, can access the website. And you can filter out information on credentials, cost, type of insurance, area of specialization, language, location, and so forth. So the goal is to try to link families much more quickly to Tier 2 and Tier 3 services. Now, the nice thing about community asset maps is that you can use them also for research purposes. So you can identify characteristics, for example, of mental health providers in a given area to sort of more closely identify what kind of obstacles might be out there. So this is sort of summary information of the over 1,000 mental health providers that we collected information on for Clark County. You can see that the largest segment of mental health care providers are actually students who are not yet licensed. Sort of pre-professionals, if you will. Only about 8% were psychologists. The cost per session was $130. What we found is that only about 40% accepted Medicaid or had some kind of sliding scale for a reduced cost. Less than 60% accepted insurance, and if they did, it was only about 4 plans that they accepted. And less than a quarter had expertise with children. Even though about 2/3 had expertise with adolescents, less than a quarter had expertise with child behavior disorders, so those problems that are affecting kids less than age 12 years. Another nice aspect about community asset maps in terms of research purposes is that you can convert them to choropleth maps or theme-based maps that use different shading patterns or colors to kind of represent the average values of a variable within defined areas such as neighborhoods. So typically darker shades will represent a higher value or more density, whereas lighter shades indicate lower values. This choropleth map obviously is Clark County, and it illustrates the density of mental health providers per students that are enrolled in the different middle school catchment areas. The gray areas represent mental health deserts where there's no providers whatsoever. So I know that this is not as easy to digest, so what we also did was kind of zoom it in a little bit for the Las Vegas Valley, and this shows areas where the mental health providers are more densely packed according to the middle school catchment areas. And what you can see in general is that you tend to have a higher density of mental health providers around the ring of Las Vegas Valley, right? Tend to co-occur where you have more affluent areas of the valley. We also did an analysis looking at the density of mental health providers vis-a-vis chronic absenteeism rates in each of those middle school catchment areas. And what we found is that basically there was a relationship. So the number of mental health providers was a significant negative predictor of chronic absenteeism in middle school. So the more mental health providers you tended to have in a particular area, the higher the density, the lower the chronic absenteeism rate. Now that's correlation only. There's a lot of third variables that can explain that. But what we did find is that chronic absenteeism rates did decrease by 0.09% for each additional provider that was available. If you added high schools to the mix, there's a lower number. You still got an effect of about 0.07%. Theoretically, what that means is that if you had 50 extra providers in a given area, you would decrease the chronic absenteeism rate by 3.5%, right? But in general, what it means is that the more mental health providers you have, as you're dealing with a lot of these mental health kind of conditions, you've got a lower rate of chronic absenteeism. So the other main part of that project, the Cooperative Extension Project, was to pilot an MTSS approach for preschool and a kindergarten setting here in Las Vegas. So as I mentioned, a lot of MTSS approaches tend to be done in high schools, middle schools, kind of late elementary schools. Almost none are done in kindergarten and first grade settings or preschool settings, but that's unfortunate because that's when a lot of mental health, behavioral, and school attendance challenges actually begin. And so what we did was we assisted the school-based personnel at those sites with tier 1 practices of monitoring school attendance rates. What schools often do is that they only look at their school attendance rates maybe every other week or once a month. What we did is we actually had people down there at the sites every single day monitoring the attendance and catching these problems as quickly as possible. At tier 2, if a student missed at least 25% of school time, we worked very closely with the in-house personnel there to develop intervention plans to kind of minimize the absences and improve the mental health and behavioral functioning of the kids that were experiencing the absences. There were several kids that moved to tier 3, so they had very chronic and severe kind of absenteeism. And so we worked with the school officials to kind of link the families to community-based care options as possible. So just to give you kind of a snapshot at Battleborn Academy, we worked with 5 K-1 classrooms there. There's a total of 87 students. Almost half were identified as having significant absentee and or tardiness concerns. So this was ramped up in the fall of 2024 and continued into the spring of 2025. So I kind of split the academic year here. We started out among that group with about 168 absences and 161 tardies. As we ramped up the program and we were able to kind of pinpoint exactly what kind of challenges we were dealing with, and a lot of times it was behavioral, but a lot of times it was economic. And so a lot of the interventions didn't just involve any kind of like family-based intervention. It also involved things like gift cards for ride shares, bus passes, and things like that to try to overcome some of the transportation vulnerabilities that a lot of these families had. But what we found in the spring is that we had a 15% reduction in absences and a 25% reduction in tardiness rates. Now, unfortunately, Battleborn closed suddenly and unexpectedly right at the end of the year. We didn't anticipate that. So we're currently collecting long-term follow-up data. We're trying to identify the 41 students that got scattered among the 4 winds. We actually found 30 of them so far. So we're collecting long-term follow-up data to sort of see how they're doing now. But the other thing that we did was we interviewed the parents and the school officials quite a bit about, well, what are some of the main reasons why we're experiencing such high rates of absenteeism and tardiness? One of the things that we didn't really think about going in was the fact that this was the very first cohort that had been born primarily during the main pandemic shutdown era. So I didn't actually piece that together until later. But what that meant was, what the parents were telling us is that because of that, there were long delays in enrolling their kids in preschool and daycare options and the services that were available there. For many of the kids that we saw, the very first time they showed up at these schools was the very first time they had been out of their house for an extended period of time. And so you had a lot of problems with emotional regulation, social skill challenges. The families a lot of times had very chaotic morning school preparation routines. We did a variety of workshops and interventions just to kind of systematize the routines. The families also reported that because of the pandemic, they had a lot of changes in their transportation, housing, and childcare arrangements. So it wasn't unusual for multiple families to move into one household. And what that meant was that if one child was sick, 6 kids were absent that day. Or if the car wasn't available or it broke down that particular day, the entire household didn't make it to school, right? So a lot of these kind of pandemic-related things have lingered quite a bit over time. Now, as I mentioned, part of the mandate for the Cooperative Extension Grant is to partner with the Reno folks, and so as I mentioned, we've done that with respect to more statewide MTSS kind of procedures. I'm not gonna go through all of this, but I just wanna focus on a couple of projects that we've done with them. The first was to kind of look at rural schools in Nevada. So Nevada actually has 37 rural and what's called frontier schools. And a lot of MTSS procedures are actually done in urban and suburban areas, but very few have been done in rural areas. So one thing that we wanted to look at was sort of the development of MTSS procedures in rural schools in Nevada from 2019 to 2023. And we wanted to see if the implementation of those, if they had good fidelity or good adherence, was necessarily related to positive student outcomes. So theoretically, what should happen is, if a school is practicing MTSS procedures, they're identifying kids early in the process, they're linking them to appropriate care, you should see improvements in attendance and other kinds of student outcomes. So the main question is, does better fidelity to those procedures necessarily relate to those improved outcomes? Now, we looked at a variety of outcomes. Just for snapshot purposes, I'm gonna focus more on school attendance. The first thing that we looked at was sort of in a given particular year. So these graphs show the association of Tier 2 fidelity with attendance rates and chronic absenteeism rates in a particular year. Now you can see there's no relationship pretty much at all. So schools that had low fidelity versus high fidelity in any particular given year, not much of a change. But remember, we're looking at this from 2019 to 2023. So what we really wanted to do was sort of look at changes over time, and that's where a lot of these obvious changes came into being. So I want to spend a little bit more time on this. Basically, we found that there were 2 main types of schools. So one type of school, one group of schools, had good fidelity with the procedures. Maybe they started out and it was kind of a feel your way process, but they stuck with it, right? They continued to problem solve. They got a lot of feedback from the MTSS team and the Department of Education. They stuck with it. And what you see over time, the schools that have more strong fidelity are represented by the darker line. You tend to see at least stability in average daily attendance rates and a decline in chronic absenteeism rates. Now, the other group of schools started out with decent fidelity, but they kind of gave up on the procedures over time. Maybe it was too unwieldy, too burdensome, just too many administrative constraints. And so the fidelity actually declined over time. But what we found is that those schools, which are represented by the lighter line, actually had declines over time in terms of average daily attendance and a substantial increase in chronic absenteeism. We also looked at Tier 2 fidelity rates, and we saw a very similar kind of pattern. Again, schools that have higher fidelity tend to do better in terms of daily attendance and chronic absenteeism rates. Schools that kind of give up on the process over the time tend to have worse rates. So basically, the moral of this story is you kind of have to stick with it. If you just look at findings in a given year, it washes out a little bit. You really have to sort of see whether you have improvements or not over the course of the timeline. Now, the tier 3 procedures in this were sort of developed at the very end of the longitudinal period, so we really only have correlations, but basically they're trending in the right direction. So the fidelity to tier 3 procedures, you also tend to see less chronic absenteeism, a little bit of a boost in average daily attendance. You also see declines in alcohol and weapons events. We're looking at a variety of other outcomes as well. And then the other aspect that we've been collaborating with them, the Reno folks with, is sort of looking at the fidelity to MTSS procedures and whether they have an impact on special education rates. So for many schools, when they're encountering a student that has a mental health or a behavioral challenge, they don't quite know what to do with them, and so what they do is they place them in special education, which is not always the best academic or other placement for a child that has a mental health or a behavioral challenge. If you've got good fidelity to MTSS procedures, ideally what you would see is lower special education referral and eligibility rates and lower IEP rates overall. So these are just preliminary data, but already that's sort of what we're seeing. Basically, the early finding is that more adherence to MTSS procedures relates to lower IEP rates, not just in a given year, but also in the following year. And so we're going to be continuing to work through this. I'm working with a statistician now to kind of look at the broader data. We've also started some other projects with the Reno folks. We're going to look at charter schools in particular, and then we want to look at all of the Nevada schools to sort of see how fidelity to MTSS procedures relates to student outcomes. Now, as I mentioned earlier, the other sort of main pathway to dealing with, to try to advance the state of mental health in children and adolescents is to try to augment the mental health workforce. And so the two programs that we've worked to design over the last 12 to 18 months or so is a PsyD in clinical psychology. This will be the first program in Nevada to train psychologists via a clinical practice practitioner scholar model. It's more clinically focused. The advantage of a PsyD over a PhD program in psychology is that the graduates can usually get out of the program a little bit quicker. You can also have larger cohort sizes. So in a typical PhD program, I have 6 to 8 students a year, but a PsyD program can handle about 20 to 25 students per year. This one will, in particular, will have a pediatric focus. We also got funding, as I mentioned, to develop a bachelor's program in children's behavioral health psychology. This will be this is modeled after the Balmer Institute in Oregon. It's a bachelor level profession that's going to allow graduates to practice those tier 1 kind of procedures, screening, prevention, early intervention, under some kind of supervision. And so there's 6 main program standards. I'm going to show you the curriculum maps in a little bit, in addition to an addictions focus. And again, this will align with the new state category of behavioral health and wellness practitioner that will allow folks at the bachelor's level to be licensed to be able to provide these services, and we'll be working with the Nevada Board of Psychological Examiners to do that. So both these programs are currently going through the curriculum review process. They're slated to begin in the fall of 2027. Both of them also will have a Spanish emphasis for students that want to do that, to try to reach a broader level of folks in the community. So just to give you a little bit of a snapshot of the curriculum maps, in particular, I want to point out Dr. Erica Hanna, Dr. Heather Thompson, and the 2 consultants that we've worked with, Wendy Paskowitz and Kevin Austin Garner, of course, Dr. Michelle Paul, and I as well. So it's been a collective effort, but those folks have really put in a tremendous amount of effort to develop this really wonderful curriculum map. It'll be based on a trimester model, which we'll have to see how that fits into the structure of UNLV. But basically, this slide kind of gives you a little bit of an indication of some of the more foundational curriculum for this PsyD program. Basically, it's going to be a strong developmental focus to address families and youth. This particular slide shows some of the assessment curriculum for the PsyD program. It's going to have a strong focus on neuropsychological evaluation, especially for children that were gestationally exposed to substances. There's a 2-year wait list for those folks in Nevada. Because the program is coming out of opioid settlement funds, there was kind of a mandate to make sure that we have procedures in place to address that population. And then this just gives you a little bit of a snapshot of the treatment curriculum for the PsyD program. It'll have a strong focus on family systems and family-based interventions. The next couple of slides just give you kind of an illustration of the curriculum for the new bachelor's degree in children's behavioral health psychology. So I've been working on this with the Balmer folks and the internal UNLV folks over the last year or so. This was just approved by the Department of Psychology faculty, which is a nice hurdle to get over. And now it'll start the college and the university and the region's curriculum review process. Again, we're hoping that this will be available starting in the fall of 2027. So this particular slide shows the curriculum for the main general track. You'll see that there's going to be a variety of new children's behavioral health psychology courses that are based on the Balmer program standards. So where you see S1, S6, S4, that actually is the course that corresponds with that particular Balmer standard. We also added, as I mentioned earlier, a CBHP addictions course, given the opioid settlement fund basis for the program. This will also involve 700 hours of practicum experience that will involve consultation, supervision, and direct intervention. And then students can take a variety of elective courses from units across the campus. It could be healthcare provider skills, psychopathology, multicultural issues and counseling, social work, human services, and a variety of other kinds of courses. And then this snapshot shows you the health psychology program for one of the Spanish concentrations. Again, this will allow graduates to reach a broader cross-section of families if they want to do that. There's actually two concentrations. There's one for heritage speakers, those that can largely speak Spanish coming in. This one is more for non-heritage speakers, and so it's a little heavier on the Spanish curriculum. But again, this is designed to try to give them a broader basis, and special thanks to the folks in World Languages and Cultures who've partnered with us on this set of curricula. And then just to kind of finish up, there's some additional resources from SB 165. So there was funds that were in that bill to establish a micro-credential curriculum, and basically this is going to be spread across three main NSHE institutions. Here at Nevada, we're going to be developing the curriculum to train clinical supervisors for the undergraduate students. In Reno, they're going to be focusing on recertifying people that might have a different degree, but they want to be certified as a behavioral health and wellness practitioner. And then the folks at Great Basin College will be focusing more on teachers who want to work with or as a behavioral health and wellness practitioner. There's money in the bill for scholarships for students that are going to be in these programs, for incentives for the supervisors to be able to take the curriculum. There's funds in there to actually implement the degree program, as well as to find people that can help us collect information that's going to be part of the curriculum and then put it in website modular form. So the idea is that we want to make it as easy as possible for the supervisors to go through the training as they're signing up to evaluate and train a lot of these undergraduate students. There's also funds in there that'll be for program evaluation across the NSHE institutions and to develop a pediatric clinical internship via the practice. Dr. Michelle Paul is largely leading that particular effort. So I know that's a lot of information. I just want to say thank you again. It's been a lot of work. If any people here want to talk about collaborating in different kind of ways, Kellyanne and I are certainly open to that. We were talking earlier about how, there's obviously a lot of people that are involved in these kind of efforts and related kind of efforts. So we're definitely open to any kind of outreach and collaboration in that regard. Thank you.
Hi, everyone. Thank you for being here this morning. I wanted to follow Chris's presentation about the details of his discoveries and work over the last couple years with the discussion about what I've observed while participating in this grant and engaging with community organizations and leaders to really focus on what it means to be present for children in Nevada and to talk about the value and evolution of coordination, research, innovation, and advocacy in our region. So without further ado, I will talk about that. The first thing I want to talk about is something that a lot of you all know, which is that Since 2001, we have had a mandated state-level children's behavioral health consortium. So these are regional and statewide, and it is important to continue to be in touch with what they are releasing. They are always producing new reports and data and gathering understandings of what's happening throughout the state. And so if any of you are pursuing work related to youth mental health, this is definitely something to stay attuned with. Oops. Make sure I didn't skip one. All right. More broadly, you are working within an enormous ecosystem of individuals who care about children's mental health in Nevada. And this is just a glimpse of some of the many organizations and ways in which organizations are focusing their efforts and partnering to critically think about how to solve some of the very dire challenges that Dr. Carney spoke about and that many of you are acutely aware of. I think this slide is especially beautiful to look at because this is honoring what's already happening. This is a scary time for many of the people who are working among this ecosystem, and I recognize that this is just a snapshot. There are many more organizations that could be listed here, but I think one of the more valuable takeaways from my experience in engaging with the people who are working who are working with such effort and commitment on these projects is that nobody is working on this alone and nobody is going to come up with the solution to all of these problems. So one of the most important things at this time is to deeply think about ways to communicate with others about what you're doing and align efforts and devise partnerships that are different from the way we may have in the past worked together or separately, because there's not a playbook for what we're going through right now in terms of not only children's mental health, but adult mental health, what's happening at multiple levels of government, and the context within which we're all working. So I hope that you will also take away what I take away from a glimpse at this ecosystem, which is to say that this is vast and deep, and it is not something that has just been pulled together in the last year or two. This is something people have cared about for a long period of time. It's important that I talk about what the bad news is. None of this is good. But it is good that we have this information. And it is good that many of you, I'm sure, look at this information and already know this information. Because having an awareness of what the state of play is throughout these systems allows us to really focus on the aspects of this that are keeping people up at night. And for me, the aspect of this that really keeps me up at night is 73% of Nevada youth who have experienced a major depressive episode have not received the needed treatment. This is not only a travesty for those individuals and their families, it's a travesty for the workforce who is, pushing ahead to bridge these gaps and build relationships with them. And I think it is fortunate, and we can acknowledge at an event like this, that we have advanced our capacity to reach young people significantly from where we were 10 years ago, and that even though this is a scary time, there are a lot of people engaging in the conversation that can help ensure that some of these blind spots, so to speak, do not continue to be blind spots. Again, a sobering aspect of this conversation is that it is getting harder, not easier. So federal funding for mental health in Nevada was cut by over $22 million this year. And many of you know that the ARPA behavioral health grants also expired recently. So there are a lot of things that we're working that do not have the resources shored under them that they used to. in addition to the fact that this is a hard time to be a young person, it is a hard time to be an adult in terms of mental health. So I want two things. To get to the third bullet point, I have also been attending the United Way of Southern Nevada nonprofit connection calls that happen once a month. And if you're not engaging with these, regardless of whether you are working as part of a nonprofit organization, I would strongly encourage you to try to make time to tune into them, because it is a great way to get an immediate pulse on what is happening in the organizations that are providing service in a number of ways in our community. You probably know that many of these individuals are reporting having to reduce staff and services at a time of great need, and that this is happening increasingly and probably only looking to happen more as we go forward. What I value about these calls is that it's a place where people can immediately ask for help with something that is happening next Wednesday, and there's another 85 people on the call to say, I have a group who can help with that, I can help finding volunteers, we have stockpiles of food if you're running out of food for the lines that are increasing every month, which is one of the things that was discussed last time. And so come to listen, come to ask for help, come to offer help, but it is an important aspect of what's happening, and I'd be happy to share that information with anyone who may not have that information after this event. That call started during the pandemic. And it started early in the pandemic as a response to the fact that there wasn't yet a mechanism for quickly coordinating everyone to say, all hands on deck, we have to figure out what to do this afternoon. And it worked. And it, by the way, when it first started, it was a conference call in which 100 people called on the telephone and tried to engage. So the call itself has also come a long way. And to the extent that we are all moving through sort of this great forgetting period as relates to the pandemic, it is important to pat yourselves on the back to realize how far we have come in our ability to communicate across technological platforms. And so how this relates to the key factors affecting youth well-being, part of that is related to pandemic disruptions. That obviously is not responsible for every challenge that a young person or a child is experiencing with their mental health, but the implications of it are only just being felt through, as Dr. Carney was describing, by realizing that some of these very young children had only just started essentially socializing upon entering school because of the necessity for social distancing during the time period in which they were toddlers. And all of this is scary, but what is really good about it, and I think is of value to look back upon when you are able to, and especially in partnership with others, is we learned a lot about how to coordinate during that time period. There were, massive and immediate coming togethers of organizations and leaders to try and address dire problems in the 48-hour window of, that next day and the following. So we can rely on what those lessons were and reflect on what those lessons were and bring that forward as we think about how to collaborate and effectively align efforts at a time when resources are being cut, and yet we still have this enormous network of people who care about this work and who are actively here for the challenge. So to the extent that anyone is feeling alone, you're not. And to the extent that you're feeling like you don't know what to do because no one knows what to do, take the time to reflect on the ways in which everybody pivoted just a couple years ago to respond to a crisis and see what we can carry forward from that. I think there's opportunity for public dialogue about that as we continue to respond to some of these needs. I want to also speak to some of the advocacy efforts that I have seen unfold during the period of time that I've been involved with this grant. I cannot explain in words how powerful it was to show up, I think in December of 2023, at the Las Vegas City Hall for what felt like just like a call to action of anybody who seemed to want to talk about children's mental health, and find myself among 100 or more individuals led by the very organized and informed Dr. Tara Rains and Councilman Knudsen, who did such an impressive job of giving the work, of giving the design of how the work would move forward to the individuals in the room, and learning and listening from the people who were meeting these challenges and hitting these walls as relates to children's mental health. And the following couple of years of the Nevada Children's Mental Health Action Coalition was also something pretty phenomenal to witness. So to the extent that you may or may not be engaged with those individuals, I think it is a really amazing thing to connect with in order to, like I said about the other call, not only gather support for your own efforts and amplify what you're doing, but also to learn about ways in which change is being actively worked toward. I also, as I talk about these resources that we have, and again, I know I'm only able to touch on some of them, it's important that I acknowledge the research center that we have here at UNLV, the Nevada Institute for Children's Policy and Research. And we are lucky to have a leader, senior research associate from that organization on our panel today. Their work has been massively meaningful to our understanding as we moved through the work of this grant, and also to the community. And I really have learned a ton from engaging with a statewide committee that they have that is working on data related to Nevada Essentials. It has really useful visualizations and dashboards about adverse childhood experiences and positive experiences. And part of, I think, what I'm evangelizing about the coming together and coalition building that's needed is also about what data is out there and available, because I know many of you are actively pursuing grants or having conversations about how to tell the story of what is happening in the populations you serve. And there are some pretty incredible data resources already out there that you could straight pull a beautiful visualization from and plop it in the document that you need to provide in order to receive the resources that you might be looking for. So not only are we the Lincy Institute a resource for that through the Data Hub like Dave talked about, but there are also a lot of excellent organizations who are also working on that to support you. There have been a number of wins, as I see it, related to advocacy in the last few years. And we have been able to reform state Medicaid in a way that affected over 20,000 children or more. The service agreement with the DOJ has proceeded onward to create statewide infrastructure and a commitment to investment. I'll talk a tad more about that in a moment. There are more certified clinicians with a rural focus. We have made advances in ensuring that it is easier for young people and children to receive treatment, and yet there is still work to be done in all of those areas. And one of the things I'm very excited to talk about that I'll touch on at the very end of my little section here is how other states are responding to the call to change the way state Medicaid is working in a way that better serves children and youth. And I think there are some great examples out there that we can continue to have conversations about potentially following. And that is something that will be talked about in the podcast that I am hosting. Some of the advocacy efforts that happened in the last couple of years didn't necessarily bear fruit. and so may have felt like failures, but I want to emphasize that these are not lost efforts. And the fact that a conversation even was initiated as widely as it was initiated about the possibility of an Office of Children's Mental and Behavioral Health at the state level is incredible. And there are many examples of actions like this that can give us motivation to push forward for future policies, to create resources and help improve coordination. And you all have the unique, intimate, and direct knowledge about what is needed, about what is working and about what isn't working. And I want to know it all, and so do a lot of the people in this room. So to the extent that space can be made to continue to have these conversations, I think there are only good things that can come from that, and that is a bulk of what I wanted to communicate in my portion of the presentation today. I talked some about these Medicaid reforms and would be happy to chat more with you all about the specifics of this. I want to make sure that we have how I'm doing on time, and that we have time for moving into our panelists. I do want to touch on this because this is, many of you know, most of you know, that a 2022 DOJ report found that we were violating the Americans with Disabilities Act by failing to provide adequate community-based services for children with behavioral health needs. We were forcing kids into institutions, sending them out of state, and it was a gut punch for this to happen, even though many people had been telling the story of the fact that this was happening for a long time and trying to make change happen. This year, Nevada committed nearly $200 million to expand community-based care and reduce reliance on institutional placements. And the reality is, yes, this is genuine progress, and there is a lot of skepticism about whether this funding alone will translate to sustained on-the-ground change. And I think this is just one example of the very significant value to staying engaged with these conversations and ensuring that things unfold in a way that is meaningful. Public sentiment is complicated, but it is still historic, and I think that we can celebrate the possibility of this changing as the beginning of a potential win. Don't get me wrong, we still rank dead last for children's mental health. We still have massive workforce shortages. We still need resources that we do not have available. And one of the main things that I think we can do to charge onward with fortitude is have conversations about various aspects of this enormous system and learn from one another and figure out where the opportunities to align are and where resources can potentially be pooled and where programs might be able to be combined or overlapped and how we can amplify messages. So that's one of the things that we will talk about as part of my podcast that will be released before the end of the year. It's one series of Conversation to Transformation. We also did a series of the same podcast during the pandemic about the impacts of the pandemic. And I look forward to the opportunity to be able to share with you what we are hearing and also to have conversations with some of you who I know I have had a chance to invite to the podcast. So do not leave. We are going to move into the panel section of the event now. And I just want to close out what I've been sharing with you by emphasizing that I want to make myself available to you, and so does the Lincy Institute and the other resources on campus, to learn about what you're doing, to learn about where we can bridge dialogue that might need to be bridged, and also what kind of research might be most meaningful for you, for us to focus on. So we will take 5 minutes to set up the panel, and then we will commence the panel. Thank you. All right. We are so lucky today to have 3 individual leaders here with us to talk about what's happening with respect to advancements in children's mental health in Nevada. We have Dr. Tara Rains, Councilman Brian Knutson, and Myra Pacheco from the Nevada Institute for Children's Research and Policy. Each of these individuals comes to this conversation with a background from a different sphere of professional experience. And I think that allows us to have a richer conversation about how we perceive what is happening and what opportunities there are ahead. So I will start off by thanking each of you so much for being here and asking, from your perspective, given your own background in this field, what do you feel is the one thing that you would change if you had a magic wand in the coming year with respect to children's mental health? We'll start with a visionary question.
Yeah. I can go. I think if I could change just one thing, would be better data integration and using that to guide policies. I think right now there is not a lot of data integration in our state, where there's a great amount of agencies that are collecting data, are analyzing data, and have all these reports, but we're not connecting with each other. And so when we are not connecting with each other, we cannot truly see the spectrum of challenges and strengths in our communities so that we can advance and leverage that. So for me, I think making data, not only that integration and connect and collaborate better, but also to be able to make data accessible to anyone so that our community has more data literacy and they can understand the current state that we're in, and we can think of more innovative ideas to improve.
Yeah, thank you for that. That's something I really appreciated about the visualizations that you all provide, and so I am grateful that you brought that up. Well, whoever would like to go next, Tara or Brian?
So I'm not a mental health professional. I'm a dad with 2 kids, and is what I would say is the biggest challenge from a dad's perspective is you don't have much of a system to plug into, and so there's a whole bunch of people doing really great work, but I can sense that they don't have a system to plug into either. There's no support network. There's no support structure. And so I think somebody has to take the reins of building out that support system, that support structure that's supported by data, that's supported by the universities who produce enough people to go into a system that is desperately lacking enough people to be in that system that doesn't exist. So it's starting it's not as hard as I think it makes it out to be. It's starting a system from scratch. It's not like you're taking a system and dismantling it and building a new one. It's starting it completely from scratch, which we just have to agree on priorities. And that would be the number one thing that I think as a community we should do, is identify what our priorities are and then just start chipping away at it.
Yeah, thank you for that. And I think some of what we heard as I had conversations throughout this grant was also hopefulness from the community that as the system comes together, the existing programs that are working will not be duplicated, right? And so I think there's an importance as we build a new system in integrating what is working on the ground.
Yeah, I think we're in a good place because people are recognizing that we have that disconnect with the data, we have this disconnect with the systems, and are intentionally working to bring it together. I think we're finally getting to a point where, as a community, where folks are recognizing that, everybody gets more when we share. So instead of replicating and doing something half doing it, right? Like, we can put resources towards something that's working really well and grow that and create supports in other systems. So I think it's just a really good time in Southern Nevada now, and I don't think we've had this kind of collective energy and working together before.
Yes, and that's something I was humbled to experience as part of the early calls of the Children's Mental Health Action Coalition, as individuals shared what their priorities are and what they were working on, and it became clear that there were simultaneous efforts toward very similar things and ways in which there might not have been awareness of this parallel effort. And it was really beautiful to see how that evolved and came together as a shared process. Do you want to talk a little bit about that and how things unfolded? Your leadership was very inspirational at that time.
Well, thank you. So the Children's Mental Health Action Coalition was actually put together by Councilman Knudsen, and it was a lot of folks who were in this room, actually. People from across the community, people from the university, practitioners, families, parents, who came together and said, hey, we want to do something about children's mental health. And so we had a convening, and we had folks rank what was important to them, and essentially just ask, like, hey, this is important to the majority. Are you comfortable if we hold tight on what's important to you? You help us get this other initiative moving, and then we'll circle back and keep your work moving. And so folks were open to doing that. And the name actually came from Ashley Pruitt at Be Here Nevada, because she's like, we're the only group doing action. And that's not true for those of you who are in the other groups. But we wanted to make sure that we had results, that there was something at the end of our meetings that we could show that we had moved the needle in some way on children's mental health.
Yeah, I loved that moment when action was added to the name, and I think it also described the moment that the organization of individuals was in, right? It evolved from a lot of conversation and dialogue and reflection into what are we going to do? And you would call these breakout groups and say, come back and tell me what you're going to do, essentially. And it was a really meaningful process. So Councilman Knudsen, perhaps you'd like to talk a little bit about how that came together and your thoughts on how it might move forward.
And we talked about this a little bit on your podcast a little while ago. It's about throwing a party. You have to do something that people want to come back to. You have to make something meaningful. And the best way to do that is you break bread, you share a drink, and you talk about personal experiences. That building a system is not as complicated. Government is not as complicated as people are making it out to be. It's go and make friends and talk about why things are important, and then figure out the details. And I think sometimes when you get to be a doctor, some of you guys are doctors in here, probably most of you, or if you're a higher education professional, you try to make things really, really complicated, and sometimes elected officials just need you to bring it down to a second or first grade level and say, this is what we need, and then we know we can work towards it together. So as an elected official, if you bring me in as a first grader, I'm gonna say, I wanna be a part of it, and I wanna champion that, and let me help you, and you can help me.
Right. Yeah, I really appreciate you sharing that aspect of it. Thank you. Myra.
Yes.
Do you want to talk about ways in which the data dashboard and the visualizations that you have might serve the Advocacy Coalition or other organizations like that? I was really impressed with the specifics of the data that you guys are gathering, and maybe you want to share a bit about that.
Yes, absolutely. So the data dashboard has a lot of different data, but the focus was our focus is to prevent adverse childhood experiences and promote positive childhood experiences. And so in my work, focusing on Prevent Child Abuse Nevada and on child abuse prevention, a lot of times, and just being a data person, you see what's wrong, right? We see we're dead last on this, we're doing terrible. And so it is important, like you mentioned, it is so relevant, and it's great to have that data, but it's also great to know what's strong. So I always say, let's not look at just what's wrong, but what is strong in our community, because there is so much strength, there is so much resilience, there are so many good things happening that they get overshadowed by us focusing on all the negative. And so with our data dashboard, we wanted to highlight some of those positive childhood experiences that children are experiencing in our state, that we can use to leverage that. So we have information in school settings and school environments and home environments. So having a caregiver that listens to them, having connections to when they have a problem, they have someone that they can connect them to resources, right? So we have different data points that we're collecting on that we are hoping that our community can use to leverage that out. We want to make the data, our data dashboard, we worked so hard on it to make it as accessible as possible so that hopefully agencies can use it for their grant proposals, because we know that data is important for that. So we're trying to make it as accessible and as easy to understand as possible for you to be able to see in specific counties, because we know that the rural and frontier areas tends to get overshadowed as well. So we want to make sure that we can highlight that and we can focus on those areas as well. So we also created infographics on mental health and the state of mental health depending on the county, for you to be able to get a better grasp on what is going on and how that is affecting also with adverse childhood experiences, and how many how many of those are having some negative mental health outcomes due to the adverse childhood experiences that they had to go through in their life. So yeah, we just tried to make tools as easy and accessible, because I know that, sometimes the reports are so lengthy and they're not easily to understand. So we did work with families as well. So we showed the data dashboard, the infographics to families in our state and said, does this make sense to you? Since you don't know anything, you didn't do the research, right? So for me, it's really easy to understand what's going on. But for you, can you tell what this graph means? And so we provided that, and that we got that feedback and worked together with families in our state, with agencies in our communities to make sure that it was something that can truly be used.
That's amazing. And it also bridges well into the next question I was going to ask, which is that it can be challenging for families, very challenging to navigate the fragmented system that we've talked about. And I wondered if there is one way that each of you might suggest a concrete change that could help make it easier for families to access the care they need or learn about what resources are out there. I think you just gave a great example of what you were already doing, but I do also really appreciate that you have a lot of experience working with families directly, and I think that's a very important part of the conversation.
I think we can offer families support in navigating. So I'm just going to do my shameless plug. So my job with the Balmer Institute is to help grow a profession of bachelor's level mental health professionals to work explicitly and specifically on health promotion and on prevention of the escalation of mental health distress. Those folks, that workforce is poised to help families navigate the system, right? Like I feel like I have a lot of privilege. I work at home, I can do drop off and I can do pickup and work a full-time job. And if I had to navigate the uphill climb of finding supports and services for my kids, I don't know that I would do that on the regular basis, right? Like, I feel like I have a hard enough time making sure they get to their well checks. So asking families to do the lift of navigating our fragmented system is setting them up for failure. Like I commend any parent we get that calls in and gets through and shows up for the appointment, right? Like they get all the high fives for following all those steps. And so we have to create a workforce of folks who can kind of support them and give them tools and strategies that they can use while they're waiting for those appointments, right? So that they're not just languishing while they're waiting.
I would say as a parent, navigating what I don't consider it a system, because I'm the most accessed, most resourced person you're going to find. I got connections everywhere, and I cannot figure out services for my own kids. Cannot do it. Like it's very, very challenging. So I just want to paint a different picture, talking about the data and the graphics and how to get families involved, like how to make systemic change at the state level, because that's really kind of where we all need to kind of focus in on. When we went to Oregon to learn about the Balmer Institute, we flew educators within the higher education system there. We flew legislators there to help find a common group of people that could share a story together. And we went there, and the most telling moment of that time was we toured the Balmer Institute, we did dinner, we did drinks, and then all of the university people went to a whiteboard and started like mapping out curriculum. And the legislators, the people who make decisions, sat there alone, and they came up to me and said, "Why are we here? I don't get what my role is." And so we were up until 2 a.m. with the educators and me, doing very irresponsible adult things, talking about how we bridge that gap. How do you get elected officials to understand what's needed, what their job is? And it wasn't until 4 o'clock in the morning when Michelle Paul texted me and says, "We need a Medicaid change and we need a professional license." That's an action item that an elected official can understand. So those are 2 sentences that were in bullet points, and it became a bill. So that is what I think needs to happen, at least from my perspective, is give me something that I can comprehend. And I don't necessarily need to understand the entire mental health care system. As an elected official, I need to understand what bullet points I need to work on. And then your job is to use all your data, all your graphics, and help figure out how to support that so that when people come and attack, and they will attack, that you have a defense mechanism. Right. So that's kind of how it happened, and that's what should happen next time. That's how all elected officials should be thinking about this, is find a support group of people who can make it simple enough for me to pass a law, because laws are not that complicated. They're a sentence in a paragraph.
I want to echo that. I was guilty at the board, and then Chris came along and did it better.
She started it. It was her fault.
I know. I was like, let's draw this out. And I will say, I also want to second what you said about making it simpler. I met with several legislators, and they were like, less words. Less words, right? And and as academics, like, it gets hard because I want you to deeply understand exactly what I'm doing and why we're doing it and where it came from and who studied it 30 years ago that got us to this point, right? And I don't know that that's what folks need all the time. And so I encourage you all to use ChatGPT. I did. That's how we came up with those 2 bullet points. We're like, take it down.
They told me they came up with it on their own. So that's very disappointing.
There were so many words when we did it. There were so many words. So, but I think that's important, is that when we have these initiatives, that they're clear, right? And there's an actionable solution, and there's evidence when you need it, right? Because there was a time during the session where people are like, prove it, right? And for those prove it people, you need that information, but not everybody is the prove it person. And so I think as we're moving these initiatives forward, that we need to be intentional, be clear, and be solution oriented.
Absolutely. I think being solution-oriented is so important because, again, I think we focus a lot on the problem, and then we don't provide legislators, with potential solutions and have those backed up with that data for when attacks come. So I do think it has to be a very comprehensive approach of saying, like, yes, let's state the need, state the problem, but these are the potential solutions. This is how they can be feasible in our state, and here's the data to prove it, right? And so I think we all need to work together on that, and I think a lot of times we're just working out very, very separate, and I think that's why a lot of things take so much time to go through. But going back to your comment on having more workforce, right, that can connect families to services, and then that original question, I think it is so important to create a culture of no wrong door, right? That yes, I can maybe in my professional manner, I cannot help you in these services, but let me connect you to someone that can. Let me reach out, let me make a call. Instead of just saying call 211, instead of saying here's a brochure, right? I think it is so important for us to be able to create a culture where we're not just closing the door on people. We're saying, I care and I cannot provide this, but I can connect. I can do my best to connect you to someone. And I'll just share a little bit of a story. I used to work for communities in schools for about 7 years, and they provide wraparound services for students. And then I stopped working there. I came to UNLV because I wanted to work more with policy and research and just create more high-level impact, right? But I loved what I did working one-on-one with students. About 5 years after I left, I got a call from one of the parents that I worked with because just trigger warning, one of my students attempted suicide. And she didn't know what to do. She didn't know who to connect. All she thought of is reaching out to me. And and I'm emotional, I'm sorry, I'm a Pisces, and I cry for everything. But while I felt very honored that she felt comfortable to reach out to me, I was just thinking, the school has services. What happened where she did not feel comfortable or she did not know that she could reach out for support at that school level, at the community agency level? Right? That she felt that I was the place to call. Yeah. And so I think being able to create a culture within our agencies and communities where there's no wrong door policy and we're just letting them know, hey, I'm here to support you in what I can. Even if it's outside of my scope, I can try to connect you. I think that will create such a bigger impact.
I would just weigh in as a parent because I've been in those situations. So everybody opens their door for me. Like it's a super nice position to be in this job because everybody will open their door, and I challenge you to shut a door in my face. Like, don't do that. But everyone opens their door and they say, I'm going to give you resource after resource after resource, and I'll call those resources, and they'll say, we will take you in. We have an appointment available in 9 months. And if you're a parent, like that is just like having your door shut and someone like smashing you in the face. Right. And that is for me. It's a 9-month waiting list unless you go on the black market, which there's a lot of people on the black market, and you pay cash for these kinds of services. It's crazy.
Yeah, I was thinking, thank you for bringing up that reality of trying to navigate a system that only has so many doors and they only lead to so many places, because I spent some time over the course of this grant learning about what no wrong door approaches meant, because there was a potential grant available that the state could apply for if they could prove that they had that kind of work underway and a sort of system in which to facilitate improving it. And what I realized is how often a person who is a part of the system might answer the phone and have no idea what door it is that they need to even maybe direct the person to. And I'm not just saying that to like be concerned about it. I think it's actually a really interesting way to approach policy conversations about solutions, to think about no wrong door and talk about, if someone called and asked you this, would you have any idea what to tell them to do? And if you don't, that becomes a thing that needs to be sort of formally explored as far as how a solution can be born from that. And the time lag in ability to receive services for children is also a really important part of that picture, because there are so many aspects of service for mental health that are immediate and cannot be useful in 9 months in the same way that they need to be useful the next morning. So thank you for sharing that aspect.
I wonder if, one of the challenges it feels like we face is that folks don't know who's doing what around town, right? When I think about other cities that I've lived in, like there's always kind of been a hub person that or organization or agency, and everyone's like, oh, you don't know where to go, you can always go check with so-and-so.
Right.
You can always go check with, right? And I think, as I'm thinking about the other, like Atlanta and Denver and LA, that hub, and a lot of times has been the children's hospital, right? And so we're excited that we're finally getting a standalone children's hospital here in Nevada, and I'm hoping, and I'm looking at Eric, because I know he advocated for it. I'm hoping that we can come together and partner with those folks so that they know what programs are out there and they know what green spots are out there, and they can partner. Because if you're in Los Angeles County and your child is thinking of suicide or you're having a major problem, even if they can't support you, you can call the hospital, right? You call the mental health portion of CHLA and they'll say, like, that's not our fit, but here's where you can go, right? Like, they have the resources and have the referral, and that's more likely something that parents would think to do. And we don't have that hub here. And I'm hoping that we're moving in that direction, and that can be helpful and help people with the no wrong door.
Yeah, and I think the specifics you've all described also give an interesting spin on what needs to be considered in terms of operations as those resources actually become real, in terms of, for example, the Children's Hospital. There's a lot of aspects of the operations that will be largely influential to whether or not those kinds of aspects unfold. So continue to articulate what you need, I guess, is the message.
Do we do education on programs? Like, have you gone, I'm thinking about the first episode psychosis program, right? Like, have there been opportunities to just meet with all the pediatricians or meet with all the school principals and meet with, right? Like, have we done any of that work?
Funny you ask, because we're not a pediatric access officer, but also in health does precisely that.
Okay.
And yes, we do a lot of outreach. We've just started, as you are intimately involved.
Yes, the ECHO.
The Project ECHO for Basics on Pediatric Mental Health that we're piloting internally at the UNLV programs will make statewide. And so we are, but we have a limited bandwidth of individuals, and funding, as we know, is always the challenge. And so when you talk about watering green spots, we have some amazing green spots at our department in psychology and others. And with all of these changes, as you articulated in the slide earlier, we are being hamstrung in our ability to maximize the benefit of these green spots. And it's such an uphill climb right now.
Yeah. We need billboards, Councilman.
I can probably get you a billboard. Do you know what you're going to put on it?
Yes. I do.
Okay, I'll get you a billboard.
Okay, awesome. See how that works?
QR code, fund
Yes,
our program.
yes, yeah.
Oh, I love that.
Yeah,
Cash
yeah.
App. Cash App
Right,
program.
the QR code.
And I have to streak my Venmo.
I want to do two things. One, respond to what you were sharing by encouraging each of you. I'll follow up with this via email after the event, but I created a Google form for any of you that are aware of an initiative or a program or an individual or experiencing a challenge or an opportunity that you think, I wish that would have been talked about today, or you think it's something we should be aware of, or that you want to shout from the mountaintop. And I would like to receive that information so that we can move forward, and grow from the fact that you chose to be here this morning. So that's one thing I wanted to say, and thank you for the work that you're doing. And then I have one last question for you all, and then I think we have some time to open it up for questions and conversation in the room, because I know there are a lot of individual voices in the room here, and I'm really excited to engage with those folks in the audience as well. So my question for you all is, can you think of an example? What is your example of a partnership or initiative at this moment that is working, that you are excited about seeing move forward? And I think to the tune of focusing on what is strong in addition to what is wrong, what would you point to?
I would point to SB 165. We have 3 universities across the state working together to stand up these bachelor's level mental health programs. In addition, we have 3 universities working on micro-credentials to support supervisors, to support recertifications, to support teachers. And we also have funding for scholarships for people who are gonna be supervisors of the bachelor's mental health professionals. I mean, I know I'm a Nevada transplant, but I have not seen all of the universities come together with the state, with Health and Human Services, and execute a plan in sync-ish, like we're doing our best, we're still human. But it's moving and it's working. And so for me, that's a green spot to be watered. And it's an initiative to be uplifted to show that it can happen, right? Like, if we share, everybody wins. I was having a conversation earlier about how we sometimes can get competitive in our own spaces, but by saying, you know what, hey, you take this piece may actually set you up to get more later, right? Because people see that you were generous and able to give and to support a piece that we know is working. And so I think SB 165 is definitely something to highlight.
Thank you for that.
I would say, like, as a group of mental health people, so I'm just a dad and I have a fortunate job of being an elected official, but as a group of mental health people, I don't distinguish. I just say all in that mental health space, all specifically around children's mental health. You're ripe for like leadership and growing. Like, you can see it, the energy is there, and it's palpable that it's something. As long as everyone stays together and works together and agrees on priorities, it's ripe to move forward. I work with lots and lots of different kinds of groups, and not everybody is as ready to move forward as this group is. One of the requests that I would make, and maybe the Lincy Institute can help, I don't know, but I think it would make it easier if we were to identify what are all when we talk about opening doors, there's not enough doors. Like, there just isn't. So if you were to talk through what are the needs in Nevada with regards to mental health and the mental health professionals that support that, what are the needs, what are the gaps, and then help prioritize. I think a lot of it's, at least my conversations are around, we need supervisors and we need students. And we need places for them to go after. That's going to start with the system of higher education. And so if we understand what are those gaps and how the systems are already filling those gaps or not filling those gaps, that helps us clearly identify priorities. I don't know if the Lincy Institute does that. I don't know who does that. But that would be the next clear step, I think, for the legislature to say, we know we have these 15 positions that we need to fill. Here's our top 3 priorities. Let's work towards those in the next session.
That's great. That's why we have these kinds of conversations. Thank you for that.
Absolutely.
Myra?
I do think with that, just addition of retention, that is something especially in the rural areas and frontier areas where there is no retention when it comes to mental health professionals or just healthcare professionals overall. And so I think focusing on that, and I'll answer my question going through that. Part of the work that I've done these years have been doing like needs assessment. We did the first statewide needs assessment on child abuse prevention, created a statewide strategic plan on it. And we went through like the communities and talked about, their experiences. And I think my win on that is seeing the change in social norms, the change in that shift in culture, where when I started, and I started 7 years ago, and I would go across the state, even here in Las Vegas, and I would talk about mental health, it was still like, no, like, you suck it up, you, unless you're crazy, we don't go, right? And so those were the conversations that I would have at the beginning, right? I would train people at the library staff, and they would tell me, well, it's none of my business how the kid is feeling. Those were like word for word comments that would come to me, right? And so seeing how my experience was at the beginning, doing those interviews, and family straight up saying, I will not consider going to a psychologist. I will not consider taking my kid to therapy because we don't need it. It's not that bad, right? So from there to now, from when I did that strategic plan and I talked and they said, yes, I want to support my child. I can see some signs that let me know that my child needs help and I want to get that support. So I know that we don't have enough doors. But I also see that increase in need because people are finally realizing that, yes, I need that support. Mental health is important, right? And that has become a higher need because people are acknowledging that. And not only that, but providers are changing the way that they see us. I'm just providing this service and that's it, to saying, oh, there's more to it, right? Teachers saying, this child needs a referral to mental health support. And so I have seen that shift greatly in the years that I've been here. And for me, that's a big win because that stigma, it's very strong. And just seeing it little by little get weakened in our state, for me, that's a big win.
Thanks so much for describing that journey. I think it's really nuanced, and it is a win to recognize that we have arrived at a place where the conversations are different and there's more receptivity around the gravity of navigating everyday life, regardless of your age. Another nonprofit leader who I spoke with recently was talking about the concept of using the concept of mental fitness when communicating with youth and children to help temper the perception that what you're talking about is the things that are wrong, so that you don't somehow miss the opportunity to engage with the child about their experience because they don't want to say anything's wrong with them or wrong at all. And I think that's something we all as a species have a long way to go in evolving the way we think about too, because how we be people and engage with one another is something that we are continuing to learn about, and that has a lot to do with our mental fitness. So I'm grateful that there are a lot of professionals who are focusing on that to guide us all. And I think with that, I would love to make an opportunity to have some questions from the audience for the panel.
Start.
Here. Yeah, and please introduce yourself and your organization, if there is one, so that we
Sure.
have a
So
sense of
I'm
who's
Lee McAllister. I'm the executive director of the Nevada chapter of the American Academy of Pediatrics. I'm a volunteer there, so I have to get a paycheck. So I work for Intermountain Children's Health. So thank you, Tara, for making a plug for standalone children's hospitals. That was fantastic. But something I've been thinking about since the beginning of the presentation, speaking about having a directory of providers and information, and my experiences from Boston Children's Hospital. But children's hospitals rely on statewide 211 programs, and we have one here. It's not great. Yeah. It's not well funded. There's not good oversight. Our individual institutions and organizations should not have to track everything that's out there, because that's what the 211 program is empowered to do. And if they're not doing it, then it is legislation's responsibility to put the people in charge with the necessary funding to get that done. So I just wanted to put a plug that I don't know of any children's hospital that doesn't collaborate closely with their state 211.
Thanks, Lee.
I just want to add something in response to what you shared, Lee, that on one of the nonprofit connection calls that we had recently, the gentleman who attends the calls that is from 211 often requests, recently has started requesting for organizations to please ensure that they let him know if they have programs they're having to expire or staff reductions they're having to make because of how hard it is and how much they don't want to have the experience of telling someone where they might be able to receive help and then learning that that resource no longer exists.
So I believe other states, though, fund people at 211 to make those phone calls.
Yes, of course,
Yeah.
of course. The fact that
Definitely
this,
do. They definitely do.
the fact that this is unfolding in real
needs staff to
time.
do that.
Yes, of course he does. And so I just wanted to share that as kind of a part that I'd witnessed of a very compassionate person in a role, kind of like begging for the information he needs to do his job.
Absolutely. Thank you for making that point.
We got to get him here. Where's he? Right?
Good question.
Some of these meetings.
Good morning. Tammy Hansler, CEO for Communities and Schools of Nevada. Hello, Myra. My question is about non-clinical interventions, school-based interventions, of which communities and schools would be considered a non-clinical mental health intervention, and how that played in some of the data that we saw earlier, and how you guys are considering that as we're looking at some of these interventions, because as much as we want to get more therapists, we can't really therapy our way out of it today. So how is that playing a role in some of the things you're working on?
I mean, my dream is that in 2 years, two-ish years, you have about 400 UNLV graduates to hire who are trained in prevention and promotion, right? That's part of why this bachelor's level workforce is so sexy, is because they're trained to do some of that skill building, some of those non-clinical interventions, and also trained to spot the risk for folks who need, more support. So Megan was gonna also.
Did anyone else have anything they wanted to say
I would
in
just kind of
response
promote
to-
that again. And as a parent, teachers aren't really trained to talk to parents around issues that children are experiencing in the classroom, the behavioral issues that teachers may see, because out of a room full of 30, you're going to see a couple of kids that are acting kind of quirky. I have a quirky kid. The teacher didn't know how to tell me he was being kind of quirky, and I didn't see it myself. And so that trained workforce that Tara mentioned, like someone's got to be able to talk to a parent and say, hey, we got to intervene earlier, and here's some of the outcomes of why we would want to intervene. Because I don't think they don't teach that in the School of Education. They don't get that in your teacher license. They don't tell teachers how to talk to parents.
Yeah, I remember Amanda telling me that Amanda is the director of the Nevada Institute for Children's Research and Policy, and she was telling me that they were very proud of a win years ago that they had getting into legislative language that mental health would be required to be taught in schools, and then only to realize after that there wasn't a curriculum, right? And many teachers didn't know how to approach that. And so there was a whole, follow-up challenge about that. And so I just wanted to share that and also ask Tammy if those responses addressed what you were asking about, or if there's anything else you want to share
Megan
about
has
that.
something too.
Oh, sorry, I didn't mean to.
Here, Megan.
No. I speak loudly anyway. No, I mean, they do, because to your point, we need more educated people to be able to go and do the work. Obviously, like everything that we're all working on in this room, it also comes back to funding, because I can only hire so many people, making sure that I have the money and the resources to be able to do so.
Yeah.
Our goal always is to be in every single Title I or high need school across Nevada. I'm in 1 and 4. So I've got a long history with the largest provider. So just thinking about other ways, as you mentioned, teachers, other ways, other organizations that we can implement into schools today. As much as we want our teachers to be aware of it, we also don't want to put more on the backs of the teachers.
Yeah.
We're trying to educate our kids.
Yeah.
So the more times you can put a communities and schools site coordinator inside of a school, or a Boys Town person, or CORE, or some of those other providers, the more we can, we talked about the schools being the resource and the area for our mental health providers.
Yeah.
Let's think about putting more into our schools, so that our teachers have the resources they need to educate our kids and improve our reading and our math. So those are just some random.
And just going a little bit on that, and from a previous site coordinator, but something that I would like to see in working with CORE and Boys Town and other ones as partners, and I don't know if this already exists or is in the plan, but like a certification on mental health or something like that, that site coordinators, that case managers can take to strengthen that mental health support that they can provide.
Well, Great Basin College will be offering a micro-credential
Yay.
to give some of the skills that will be found in this behavioral health workforce. And UNR will be offering a recertification program. So if you have staff who's like, I want to learn more about these skills, they can do that recert program at UNR and have the license that says like, hey, I'm licensed to be able to support in these ways.
That'd be great.
So we're working on it.
Hi, I'm Megan Freeman. I'm a licensed psychologist, and I operate a small children's behavioral health nonprofit. We operate, excuse me, out of the Boys and Girls Clubs during after-school hours, and I wanted to build on what you said, Tammy, because we've built a really robust multi-tiered systems of support model that includes like staff training, which could be extended to teachers, as well as mental health prevention, promotion, early intervention. And our challenge is the funding. Like, completely agree that we can't lump everything at the tier 3. That's obviously not working. That's how we got here. But I'm like scrambling daily to find funding mechanisms designed for mental health prevention, promotion, early intervention. Like, I have a small amount of prevention funding through PACT Coalition, which is amazing. I'm doing a really great program with that. Like, I reached out to the state and I was like, hey, what like funding resources are there for this level of intervention? And they're like, oh, well, you got some block grant funding. And I'm like, yes, I did. That's for SED. That's not for these foundational pieces. And so this is I think we're like poised. We have so many pieces in place to scale MTSS, whatever that looks like in whatever setting you're in, but we're lacking the mechanisms to pay for the more foundational pieces, which again is like how we got here, DOJ, et cetera, et cetera. And so I think in the next session, or just like, you got to take a couple stabs at it usually, but that's a huge missing piece. And even with the children's behavioral health transformation happening with Medicaid, that's medically necessary reimbursable services. It's already like too late, you missed the foundation, and some people are always going to need that, but we're not paying enough attention to the bottom of the triangle.
I agree fully. So the U.S. Preventative Services Task Force is the group that determines what preventative services insurance has to reimburse for and what preventative services states tend to fund. There is nothing from that group on children's mental health at all. I rage applied for the group, but then I found out that you get appointed by the administration. I'm not likely to get appointed by the current administration. But if you all know anybody, if you all want to join me in rage applying every year, I encourage you to do that, because honestly, like that's the core, right? As soon as we get children's mental health, a couple of bullets saying, hey, insurance is going to have to cover this, we're going to start to see momentum in the direction that we really need to go. But right now, there's nothing for children's mental health at all. I think the only thing for children might be dental. Like, there's really nothing for children.
But to get prepared for that, you need to be very granular in your requests. That is the biggest challenge. Is in what you just said is absolutely true. Is we need more funding, we need more mechanisms of funding, but you need to define how much money you need and what are the mechanisms you need to tap into. That's the way you kind of move it into legal language, is being very, very specific.
Great, thank you for that detail, and I'd be glad to have follow-up conversations with you or Tammy about specifics that we might think through.
Hi, I'm Stephanie Lockman. I'm the director of the school psych program at Nevada State. And we do have a lot of these pathways in place. So we have a minor in school-based mental health that our undergraduates get to take. We have a post-baccalaureate for our current teachers. This was our first cohort. We had over 700 applications. A federal grant paid for all of their tuition. So they're actually getting a post-bac to understand school-based mental health, MTSS, risk behaviors, all of that. So we are offering these. We're just not receiving the same level of publicity and support as other universities are. And we also have our grad program, which we have a lot of interest in, and we are pushing out, school psychologists. Our first cohort, we need them, is in practicum right now. And their biggest issue is that they are the only provider, along with their supervisors. Their school social workers, they've left. Their counselors are rifted, they're gone. And there's no supports in our schools whatsoever. So we need to put that funding and support for the kids first. Our post-bac will help our teachers be able to identify the students who need that extra help. But as school psychologists, as Tara knows, we're supposed to be at a 1 to 500 ratio. We're lucky if we're at 1 to 1900 right now. So we definitely need some legislative support, and I'm happy to talk to you about what that would look like. So thank you.
Great, thank you so much for that. I know we exchanged information earlier, but I look forward, it sounds like you've also gathered a lot of information about this, so I look forward to learning from you about it. Any remaining questions? Speak now or forever hold your questions.
Is Lincy going to commit to my study?
I like that. I think we should continue to talk about that.
Is that a commitment?
I like it.
I like it. It's a commitment. I'm looking for a firm, solid commitment.
Here's looking at Dr. DeMoore.
I'm looking right at you, David. I know what I need to work on.
I have just one point I'd like to add. I run the largest center for gambling addiction here in the state. And I think what's really vital is for us as we're talking, this is just me throwing it in all of your brains because you're all here, but the video gaming addiction is real and it turns into gambling addiction. And gambling addiction is the highest rate of suicide ideation as well as suicide. And I just really think that as we're talking about all of these things, and I'm going to be working with some people at UNLV Health, but I just really think it's important for us to address that issue as well. It's vital moving forward. I think we're going to have this epidemic of gaming addicts moving forward just because of the lack of responsibility in our video games. Yeah. And not only that, you have prediction markets that are letting 18-year-olds go ahead and basically gamble. So I just would love to just have a conversation and just throw that out there for you all. So thank you.
That's a whole other panel.
Yeah, thank you so much for sharing that. I have a student actually in one of my policy courses who focused on policy issues related to that. And it really hits my heart when you talk about it, because I think about my nephews who are 6 and 9 and just how much they love to play their Nintendo Switch. And how you can feel in your body it being that thing that is I don't want to be in the room. I just want to escape into my little game playing, which is not necessarily a bad thing, but there's such a mental health component that goes with it. And it's really tricky to navigate conversations with children that young that are just I just want to play my game. Why are you being so horrible? And I think combined with what you were saying about the fact that they're not always responsible designed games. So I definitely would look forward to learning more from that about you, you.
No, wonderful. But I also think there's education for parents too. It's okay 100%. To be a terrible parent and tell your child you're not allowed to play anymore. You know what I mean? So I think that there's education that goes with that as well. So it is a whole new panel. But definitely things we could talk about.
It's okay to have that conversation. We had big behaviors after some video games in my house, and so we're like, you lose your mind after you play, and so you're not going to play, right? And so now there's this I promise not to lose my mind,
For sure, that's what my nephew, Minecraft is making my nephew lose his mind, and he's in the 2nd grade.
My kids don't even play it, and that's all they talk about. And I was you've never seen it before.
Yeah, same.
So if you have advice, I would love to. I need something right now.
Yeah, can we get?
Do you have a card or something?
Yeah. I got you. I do think there has to be a ton of parental education around what it means. We know it's changing circuitry and doing all types of stuff to their bodies and their brains.
Dr. Sutton in the School of Social Work, I don't know if you all talked with her, but her study is on addiction around gaming. So Dr. Sutton in Social Work would be a good resource.
Oh, great. Thank you very much. Can you spell the last name just to make sure I'm hearing you?
Look it up.
Oh, yeah, sure. No worries. Or you can let me know offline. Yeah. Thank you very much for mentioning that.
Nice. Another panel. Thanks, Kelly.
Yeah, I love it. Panels.
Wait. Governor Newsom's podcast, he recently had someone talk about video gaming. The problem is, especially young men, is that that's where their friends are.
Yeah.
And so when they're gaming, they actually are with their friends. And it's not physically there, but like it is a problem, I know, but there's so many more details to it beyond that, because if you take the gaming away, they're not seeing their friends, or maybe not seeing them, but they're not interacting with their friends.
Well, yeah, and I think it must be so challenging. I don't have children myself, so I just watch my sister navigating this, but to have those conversations about the limits, right? Are you taking it completely away, or what are you advising as far as time management? And that's where you really do need guidance of folks who have looked at this closely. So thank you for being here and mentioning that.
And for part of my work is I give positive parenting classes to parents, and gaming is one of the things that parents bring out a lot. And I think really connecting it to, well, I start by the root. I'm like, what is a game supposed to be, right? It's like fun. The moment it stops to be fun, then that's when the game is not serving its purpose, right? And like helping the child understand that. And really like talking to the parents about gaming as part of a tool for self-regulation, like as a learning experience to work on their self-regulation, right? And valuing that, yes, they can connect with people. It can be a way to have some social connections, but how to not make it dependent, and just really helping the parents understand just how to manage those behaviors is so important, and coming from the place of like patience and love, but without just saying, okay, well, I give up and here's the game, just stop crying. Right? Which is one of from the classes that I have given, that's one of the most common behaviors where parents just give up because the child is throwing a tantrum, is crying, and so they're like, have the game then, and just for another hour, and just for another hour, and that's how the kid leverages, right? So I think really implementing that in parenting classes is so important at an early age, so that way we're truly going into that primary prevention. Yes, like before they go to school and all. Yes.
Thank you so much, and thanks for telling us about those classes that you teach. That's very interesting, and this has been such a meaningful dialogue with all of you. I'm really grateful that you are here. If there was someone who was sitting tight before asking a question, you're welcome to speak up, but otherwise,
really quick.
Okay, great.
It's not really a question. I'm Mallory. I'm with Cure for the Kids Foundation and Candlelighters, which Cure for the Kids, I say, is medical. Candlelighters is more emotional and other. But I saw when you guys went to Reno or Carson City for the Mental Health Day, I actually went with Candlelighters, and we advocated on behalf of both survivors and siblings, because we've realized that there's a lot of gaps in services for siblings when it comes to medical mental health.
Wow.
So like bereaved siblings are being kind of pushed under the rug with that. So with Cure for the Kids and Candlelighters, I've been working with legislative to try to increase mental health for patients, survivors, and siblings, because also survivors tend, once you finish treatment, you're kind of done. But we're seeing a lot of, I've looked at research, we're seeing a lot of uphill battles. Once treatment's done, it's kind of a whole other thing you got to go through. So we're excited about the Children's Hospital. That's something that I've been in talks with them on the Nevada Cancer Coalition as well, and we're really needing it. And same with Renown Hospital, we're trying to get them to be more involved too.
They do that, right? Like if you go to CHOA, Atlanta, Children's LA, they offer that sibling mental health care, right? So this is another reason why having a standalone children's hospital is really an incredible opportunity for our community to grow services that have existed for decades in other parts of the country.
Yeah. Thank you so much for sharing that. We had the opportunity to tour Cure for the Kids a couple of years ago, and I'm grateful that you're here and have your voice in the conversation. Thank you so much, everyone.
Thanks.
Thank you.
Thank you.